Hello, dear jury. Thank you very much for giving me the opportunity to present my work in the final round. My name is Rudolph, and I will present my work on survival of breast cancer patients in the German-Danish border regions, which is a registry-based cohort study. First, a little background information. Before 2010, studies reported significant relative survival differences between Germany and Denmark on national level. However, these studies lacked information on stage and treatment as key prognostic factors for cancer survival. Thus, a cross-border collaboration in cancer research was established between the northernmost German federal state Schleswig-Holstein and the two neighboring regions, southern Denmark and Zealand, which you can see on the map for orientation. And within this cross-border collaboration, we were aiming to investigate regional breast cancer survival using cancer registry data, including clinical information, in order to assess whether survival differences exist in the border regions, and if so, how these can be explained. In order to answer this research question, we extracted incident invasive female breast cancer cases diagnosed between 2004 and 2013 from the population-based cancer registry of Schleswig-Holstein, and for the Danish regions from the NordCan database. In total, we extracted 46,000 cancer cases that were also followed up through December 31st, 2014. For our analysis, we excluded cases notified by death certificates only, so-called DCO cases. We also excluded cancer patients who were 90 years old or older at the time of diagnosis, and also incidental findings of cancer at autopsy were excluded. We had to exclude about 3,000 cases. So we used frequencies and proportions to describe the main characteristics of our study population. Kaplan-Meier curves and log rank tests were computed to assess survival differences between the regions, and multivariate Cox regression models were used in order to describe the association between region and survival while controlling for factors like year of diagnosis, age at diagnosis, stage and first line, or initial treatment. So in the end, our analytical sample consisted of approximately 43,000 female breast cancer cases. And as you can see on this slide, the majority of cases were diagnosed in early stages in all regions. However, the stage distribution appears to be slightly more favorable in Schleswig-Holstein. And also recorded treatment data revealed differences between the regions, especially regarding the administration of radiotherapy and systemic therapy. The proportion of patients who received radiotherapy and systemic therapy was higher in Schleswig-Holstein, especially early in the observation period. And then there was a large uptake of systemic therapies in the Danish regions by the end of the observation period. On the next slide, you can see that Kaplan-Meier curves and the log rank tests show significant survival differences between the regions. And now I will present the results of our Cox regression. So the crude Cox regression model shows significantly worse survival for both Danish regions compared to Schleswig-Holstein. In the fully adjusted model, including information on year of diagnosis, age at diagnosis, stage, and initial treatment, no statistically significant increased hazard ratios for southern Denmark persisted, while the hazard ratios for Zealand remain slightly increased, but only marginally. So the observed survival differences between the regions were actually expected, and our results are in line with existing literature, as previous studies had reported survival differences on national level before 2010. Of course, our study is not flawless, unfortunately. A limitation is the relatively high DCO rate in Schleswig-Holstein compared to the Danish regions, which may introduce a bias towards better survival in Schleswig-Holstein. However, I conducted sensitivity analysis excluding short-term survivors of 30, 60 and 90 days respectively, and it did not alter the results. This suggests only minimal bias introduced by the DCO rate. Moreover, treatment was only recorded up to 6 months after diagnosis in Denmark, which might lead to underreporting of treatment received and thus potentially incomplete adjustment in our Cox regression model. However, a major strength of our study is the large study population retrieved from cancer registries with complete registration. And also, stage and treatment data were merged for the first time in the border region, which is a novelty. So given the high data quality, we conclude that the survival difference between the regions can be explained by differences in stage distribution and treatment administration. And eventually, the long-term survival gap will close due to the introduction of national screening programs in Denmark and the increased use or administration of adjuvant cancer therapy in Denmark. Now I will close my presentation with a huge thank you for your attention and goodbye.